So welcome to our talk, Why Your Department Needs a Faculty Skills Development Program and How to Provide It. My name is Amish Aghera. I'm the Director of the Simulation Division and Fellowship at Maimonides Medical Center.
Hi, I'm David Saloum, and I am the Vice Chair of Education and the Medical Education Fellowship Director. And we are super excited to have everybody in the room today to hear us talk about one of our favorite things and hopefully convince you that you could create something very similar.
Yeah, and for those of you guys who are not super familiar with Maimonides, we're a fairly large academic hospital in the middle of Brooklyn. We have about 60 faculty on staff who primarily staff our site at Maimonides as well as a few other satellite sites as well. So we want to try to make this as relevant for you guys as possible. So we want to just quickly get to know who you guys are in your audience. If you are a medical student or any kind of student, raise your hand. All right, we got 2. Okay. Are you a resident? All right, a couple more. And are you an attending? All right, so mostly attendings. Now, for those of you attendings, you guys involved in clinical operations? Few people. How about sort of teaching administration? A lot of that. Okay. And how about just mostly clinical work? All right.
A little bit of a mixed bag.
Yeah.
Okay.
All right. So this is how we kind of often refer to ourselves, at least in our own minds. So our program launched around 7 years ago, and we were both junior faculty at the time, and this was actually much more closer to reality than was actually just like a joke. So if we were able to achieve this, it should be nothing for you guys.
And while we are very proud of the things that we have built here, I would like to say that the reason why we felt dumb and dumber, so to speak, is because we didn't really know what it was that we were trying to build when we first started. We certainly didn't have anything that we considered as a good role model to emulate. So, we kind of had to create this from scratch.
Yeah. So it's a pretty short talk. This is 20 minutes. Hopefully it will be stimulating enough to generate some questions. We don't have a really great format to be able to do this. However, if you guys are familiar with Poll Everywhere, if you log into this poll, which will be active right now, so you can either text in or if you have the Poll Everywhere app, you can send us your email address and any questions that might be generated throughout the talk. And what Dave and I will do is we'll put together a Google document later on today or tomorrow and circulate it amongst anyone who wants to get more information on this. So we'll put this up again at the end of the presentation. So if you do have questions, we'll be hanging out, or you can send it to us virtually. Okay, so as I mentioned, we've been going for about 7 years or so, and we've covered a lot of ground since then. We usually do about 3 to 4 modules a year, and we've covered a lot of sort of typical topics that you would consider germane to emergency medicine, like airway management, working on different procedural skills. And as time has evolved and new skills and technology have come into our clinical area, we focused on things like ultrasound-guided nerve blocks. We recently did a module on transesophageal echo. We've also done some other things that you wouldn't necessarily consider common for faculty skills development, like communication training with simulated patients, where we have faculty run through a sort of gauntlet of actors who yell at them for 2 hours, and they have got to figure out how to manage this conflict.
Right, and so what we're extremely proud of is that unlike many faculty development programs that are put out there, which is sort of come as you can, what we have managed to do is create a system where we have virtually 100% participation from every single attending in every single module.
That's right. So in addition to just being able to provide some content for our colleagues and staff, we've sort of noticed there's been some other benefits of being able to run a program like this. Some are some of your typical low-hanging fruit, like being able to offer CME credits, but we were also able to roll this into our hospital recredentialing cycles. which also gave it a little bit more muster. And this allowed us to then pair it with other initiatives like focused research projects, or even create some funding and apply for some grants, because it was considered, you know, a legitimate program.
Yeah, and I like to sometimes cornerly refer to myself as a educational Republican, because I believe in this concept of trickle-down education, right? So, you know, we have content experts in our departments, and instead of having those people be the one who deliver the information to our learners, like our students and our residents, instead what we do is we make sure that they actually disseminate it among the faculty, so that we are able to have full faculty participation in knowledge, and they're able to teach everybody year after year, as opposed to creating a new cycle over and over again. And this team building part of it is really great, because I think that one thing about emergency medicine that I actually found surprising after residency is that we often work in silos, right? So we might work in the same room as other faculty members, and we might even be collegiate and ask for advice once in a while, but we don't really work on teams together for the same goal, you know, in managing individual patients, for instance. So our program has allowed the faculty to have opportunities to work in pairs or small teams in order to accomplish learning objectives and goals, and it's been great. And as far as deliberate practice goes, I mean, we really believe in this model, this cycle, so to speak, where, you know, you have to teach, but you also have to give the opportunity to practice, but you have to put in an assessment part of it too in order to give feedback, and we'll talk a little bit more about that in other slides. Okay, so why did we want to start this in the first place? Well, one of the reasons is, like many people, we felt that the current system of continuing medical education and our specialties maintenance of certification left a little bit of something to be desired, right? So, you know, the kind of education that is provided is often passive rather than active education. And it's very impersonal. You know, is it the kind of education that you as an individual needs, or that your department really needs? So it doesn't really focus on what people really want for their own growth, or what departments need for their own particular idiosyncrasies.
That's right. And, you know, one of the things that's true about our specialty of emergency medicine is that we're often tasked to take care of patients with uncommon presentations that we don't get to see all the time. However, we're expected to manage them you know, in a way that care is maintained at an excellent level. It's hard to do that, you know, if you don't get to practice your skills. So it sets up a built-in mechanism for us to just do some, you know, repetitive practice. Also, you know, as time goes on and years beyond residency go on, you know, medicine evolves. I mean, for me, I graduated in 2007, so it's 12 years from now, and even just in that short time period, you know, we now manage airways completely different with, you know, video laryngoscopy. We use ultrasound even more and more. And, you know, the alternative is basically to kind of practice some of these new techniques on your patients. And, you know, I hate to use the term guinea pigs, but that's kind of what's happening when you try to do something with them for the first time. So, you know, instead of having to force yourself to travel halfway across the country to attend some course, you know, it's nice to be able to have a program that's right in your own backyard. So, you know, how do you create content in terms of, like, educational strategies? So the most important thing is it has to be engaging, you know, so you have to incorporate active learning strategies. We use simulation in our shop, but that doesn't mean you have to use simulation in yours. But the key thing is, I think, to move away from passive learning, like, you know, sitting in a lecture like this one. Although this one's very good, so it doesn't really, this one doesn't count.
Yeah, this one's okay.
Yeah, but after this, no more lectures. And, you know, one thing that's very important with learning is making sure you have a motivated learner, right? So choosing your content wisely, especially as you're getting started, as you're starting off, start with so-called quote-unquote sexy procedures, you know? There's a reason why, you know, a disproportionate amount of blogs are all about airway management and critical care. This is the stuff we enjoy reading about, right? So, you know, give the people what they want. And also, you know, Dave kind of was alluding to this earlier, but, you know, all our shops are a little different. We all don't need the same exact thing. So, you know, tailor your content to things that are most appropriate for your own clinical settings.
Right. And so along the lines of using your own resources is that you probably have these content experts within your department or people who would like to become content experts because they have a certain level of interest in a particular topic, right? So we believe as part of this active education that one of the most effective ways of learning is peer-to-peer education. And so learning from your peers is, you know, effective and I think more enjoyable really than some of the alternatives.
I mean, I know you guys don't mind but listening to me talk or Dave talk for 20 minutes, but most of our colleagues, you know, they prefer to hear it from each other.
I'm not sure that I prefer it. But anyway, and then back to this deliberate practice model, you know, in an attempt to achieve mastery of these skills. You know, there's this cycle that I talked about before, but it really requires an element of assessment, which I think is a little bit of a dark or uncomfortable word, right? Nobody really likes to be judged, and attendings are certainly no different. Nobody likes, you know, don't tell me what I know, right? So I'm done with my training. I'm done with all that. But no, that's not really the way it should be. We should all consider ourselves lifelong learners, right? And so if anybody's going to question the assessment component for a medical student or a resident as an important part of their growth, we really shouldn't be considering that any different for ourselves as lifelong learners. So we do incorporate a part of that, and we'll talk more about how to make that easier.
So how can you make this happen in your own shop? So I'm not sure if everyone in this room is familiar with Cotter or his sort of change model, but he's considered I see some nods, he's considered a thought leader in the world of sort of business management, leadership, and he's published a lot and written books around sort of his change model, which is, 8 steps to sort of drive culture change. So we're going to talk about our process and what we went through and some of the things that we did that fit into these models step by step. So number one, you have to create a sense of urgency, right? So leverage the opportunities that present themselves. I mentioned that we started around 7 years ago, and around 7 years ago, we had a very unfortunate event in our ED when we had a wrong-sided chest tube. It wasn't because the provider didn't know how to put the chest tube in, but ultimately it was thought to be related to the fact that the intern and the nurse in the room didn't feel courageous enough to be able to speak up and say that, hey, maybe this procedure was happening on the wrong side. So it gave us into a window that, we really needed to focus on building our sort of team culture and make sure the members on the lower end of our hierarchy had felt comfortable being able to speak up, and we're teaching people efficient communication strategies. So we built in a lot of team training into our early modules. We did modules alongside with our nursing staff as well to help promote this sort of team building type of activity.
Right, and we also allowed us to practice some of the things that we incorporated system-wide, right? So the timeouts. We were perhaps not great at doing those every single time. So we created a system that made it easier and a little bit more accountable to have the timeout process involved. Having monitors at the bedside that were PACS compatible so that you could review films right as you were about to do the procedure. And so it was important for us to give them the opportunity to practice these new systems processes in place along with the procedure.
So figure out who your stakeholders are, So number 2, build a guiding coalition. Probably the most important person is your chairperson. Our chair is very supportive of this program. He comes and shows up when he's scheduled, just like a full-time clinical member, faculty member does. And I think that helps a lot. The one check on here on this list that's maybe seem a little strange is our malpractice provider was actually a key stakeholder for us. Why is that? Well, malpractice is expensive. I mean, we pay tens of millions of dollars to be covered, and I think reviewing a bunch of closed claims from our system and our provider, who covers about 10 or so hospitals in the New York City area, found that we paid out like $50 million over 120 cases in a 5-year period. It's a lot of cash. So they were very happy to see that we had like a continuing skills program, and they wanted to partner with us to be able to push initiatives that they thought were also relevant to the malpractice world and the patient safety world. So that was also helped us to kind of create a lot of momentum, and in fact, they were able to give us some grant funding along the way, and we probably, collected a few $100,000 from them to help support building some of these programs.
But I think it's important that we clarify that it wasn't the money that we got from them that drove the process. Rather, we built the process, and that allowed us to generate money that we didn't even know was going to be available.
So form a strategic vision and initiatives. So we created something called an academic day.
Right. So this means, that term means something a little bit different in every shop or specialty, but for us, the academic day is something that you will see on your schedule maybe 3 to 4 times a year. It's an all-day thing. So, and what does it involve? Well, it's things that the providers asked for and wanted. They wanted protected time to be able to participate in the resident conference. So they're able to come to M&M in the morning. And then it provided an opportunity for them to participate in things that the chair wanted. So he really was interested in having more participation in our peer-to-peer reviews and in our continuing quality improvement process. So in between those two activities during the day, we provide them with education that's relevant to them.
Right. As our faculty are scheduled, they're not scheduled for a shift the night before or the same day or the night of an academic day. But it's important to note that they're not getting clinical time for this, even though it's on their schedule. It's just considered part of one of the perks, I guess, if you will, of working in our department, that we're able to provide this, and it's valued from everyone such that they're able to carve out this protected time to be able to participate. So, enlisted volunteer army. I think it's hard for any, one person to do all of this on their own. And I think we all work in environments where we work with a lot of great people who work really hard and who have a lot unique set of skills. Use them. It's much easier to be successful when you can create a cadre of 15% of your staff that are actively involved. For us, we've got a great ultrasound division, so we've been able to do some modules related to ultrasound. We're about to do one on opioid stewardship, and we have a couple of thought leaders in our department around pain management and managing the opioid crisis. So that's something we're going to do and pull them in so we can do education around topics like that. So this is an important slide. You want to anticipate why you're going to fail. And if you're able to do that and identify those potential barriers, you can plan ahead. The one thing I'll sort of point your attention to is the bottom bullet there, which is sweat equity. What do I mean by this? It's a term I stole from a colleague who, when I heard him use it, I was like, oh, I like that term. But essentially, I feel like a lot of times, you have conversation with friends and other professionals, either in your field or even outside of your field, and they say, I tried to do something and it just wasn't successful because I couldn't get someone else to do something that I needed to help promote my program. And the unfortunate thing is sometimes when you're building something new, especially if it's not commonplace, is you have to do things that are sometimes out of the scope of your job. I remember when we first started and we'd have this on the schedule, but not everyone would show up, or I had to message people and ask them, hey, you coming? What's going on? Can I reschedule you? And over time, I think people started to see the value of these sessions, and now people proactively send me texts that morning and say, hey, I'm sorry, I'm going to be late. Just don't start without me. Or they'll trade their academic day shift in advance into another day that's more feasible with their sort of work-life schedule.
Right. And so, and then this whole fear of evaluation that I have mentioned at least a couple times before, how did we get past that, right? Well, for starters, we just acknowledged what it was, right? So, and what it is was awkward. It was awkward for the person getting evaluated. It was actually awkward for us. So we had been at Maimonides for a couple of years, and we certainly had faculty that were more junior than us, but a significant number that were much more senior to us. And so, we'd sit down and talk to them and say, Yeah, I know this is weird, right? We're evaluating you, and it may be weird for you, but it's weird for us. But we're going to get through this together. We tried to create this supportive environment, someplace that was safe, so that people didn't feel scared to be judged so much, because there was really no punishment involved in this. Rather, it was supportive. If somebody didn't perform well in a procedure that we were teaching, then we would figure out a way to help teach them to do it better, whether that was within our department, just some extra practice time, or sometimes we even sent them outside of the department for education, like to the difficult airway course. We sent a few people when they were struggling with certain aspects of that. And so I think that actually helped us build this credibility that allowed us to continue this process that in the beginning was understandably awkward.
That's right. And obviously creating culture change is as a process. But along the way, you want to generate some short-term wins, right? And these are all good sort of examples of it. Give some CME credits to your staff. One thing we were able to do is sort of pair it with departmental initiatives that were important to, let's say, our chair, or do relevant activities such that we could apply for a grant and get some additional funding, do some research projects, and all of this helped us kind of keep things going. How do you sustain acceleration? They say when you start something, if you stop, it takes twice as much effort to get it going again. You've got to plan ahead. You can't let things fall off for a couple months. You just got to keep going, and then it becomes a sustaining machine. Also, we talked about, engaging your stakeholders. It's very important that you send information back to them. It's just like in a high reliability organization where you've got to tell your frontline staff about all the good that you're doing, because if they don't see it, they don't really buy into it, right? So, let your chair know what's going on. Our chair used some of our airway assessments for his OPPEs. We gave this information to our malpractice providers, and that led to sort of subsequent cycles of grant funding. So sustaining acceleration, and lastly, institute change. It didn't happen overnight, but we created value for our staff with this program, and it's not easy, as you guys can imagine, to schedule 4 or 5, 6 people on the same day. The residents are at conference, people are teaching. Our administrators have a bunch of meetings scheduled on their calendars as well. But because of the value that people see in the program, it becomes just part of the culture and part of working in our department.
And we make it happen, right? So our scheduler is constantly being challenged by many outside interests or goals that need to be accomplished simultaneously. And but she knows that this is a high priority part of our department and part of what makes us special, we think. And so it happens.
Right, and our chair is able to use this as a recruiting tool to bring new faculty on. We do it for our fellows as well. And sort of, I think we're actually running just a little bit of overtime, but in general, I'll sort of leave you with the thought that we believe that ongoing clinical skill improvement or clinical skills program is important beyond residency. We think you should try to use active learning modalities to try to achieve these goals of skill improvement, and consider using a formal change model to kind of help you move along, and Cotter's model is a great one. So again, thanks for being a great audience. You can always email us any questions about our program. I'm going to flip back to our original slide with the poll everywhere too, so you can submit a question online, and we'll create a document and get it out to everybody.
Right.
And I think we'll hang out for a little bit too. I don't think anything's starting in this room again until 3 o'clock, so we probably have a little bit of time to loiter.
Yeah. Does anybody actually have any questions they want to ask now? Oh, perfect.
You talked about having these sessions for the clinical skills. Do you ever mix in with educational skills or teaching skills to improve faculty, like bedside teaching or different modalities along that line?
That's a great...
Yeah, so Great question. And what we were trying to show is that, or trying to point out was something a little bit different than this traditional faculty development model where it is all about teaching skills or perhaps how to publish more and become more famous. We do those kind of activities also, but it doesn't necessarily have to be part of the modules that we create, which tend to be a little bit more how to make you a better provider rather than just how to make you a better teacher. We still have those kind of activities coming really from our GME office and other faculty development opportunities, which are a little bit more, come if you want to or when you can.
Although I will say that a lot of times in the midst of doing this sort of peer-to-peer education, what happens is that the concept of how do we translate this very important skill that we've just gotten better at to our residents, and oftentimes there'll be a discussion of teaching strategies and sort of a unifying, directed approach to doing something as opposed to the, you work with 30 different attendings, you get told to do it 30 different ways. The trickle-down education, if you will.
Hello, another quick question is, it seems to me that you've succeeded in getting faculty buy-in and participation and enthusiasm. I suspect that may have taken a while to get to that, and it sounds like it's all carrots now and everybody's happy and singing Kumbaya and blah, blah, blah. But I can quite readily say at our place there would be a lot of resistance getting into this. So I'm trying to just get a sense between carrots and sticks, like how do you motivate your people at the beginning to beat them into submission to start getting along and buying in? Or is that something you had to do, or did they somehow magically all just buy in and say, hey, let's all do this?
Yeah, drugs. No, Amish, maybe you're good at sticks. Why don't you talk about this?
Yeah, I do like sticks. It's funny because, I think the step one of Cotter's change model is create a sense of urgency. And the very first module we did, we had to assess all our colleagues on their skills at doing direct laryngoscopy, which kind of seems like, what? Why would you have to do this? This happened because our chairman of anesthesia mentioned in a chairs meeting that maybe we should just do all the airways in the department. And right, exactly, laughable. But of course, but our chair, who was also a relatively new chair, was like, well, we're not going to do this, so I'm just going to be proactive, and we're just going to roll out this module, and we're going to do do OPPEs and do all this stuff. And then we were like, hold on, what do you want us to do? So then we figured out, oh, you know what? We don't have no one's been trained in our department how to use a glide scope. This was we just got one into our department. So we paired it with a little bit of education. We gave out some CME, and we were really thoughtful about look, we know this is going to be a little weird. We know this is a pain in the ass. But the very first module was a mandate from the top. You have to show up. And that wasn't David or I couldn't have done that, right? That has to come from above.
Right. So, part of it is you have to have a leader in your department who is just as on board as you are about making this happen. So if your chairwoman says you're going to do it, and that's just all there is to it, then that is sort of helpful. But like Amish had mentioned before, we also rolled it into the recredentialing process. So, if you wanted to continue to have a job, you needed to check a few boxes, right? And so when you get that big recredentialing packet every 2 years that you have to, jump through a few hoops to do.
Well, we got some carrots with those sticks because by rolling it into our credentialing process is what gave us the credibility with our malpractice provider to show that it was real. And then they started giving us money. And, who doesn't like money? Does anyone have too much money in their department? Right, your simulation center has, too much stuff, right? You don't need extra money to buy stuff or, give out maybe a little, couple hours for people to do this. But it does sort of sustain itself just as long as you're thoughtful about how to launch. Because if it launches and it doesn't go well, you can forget about trying again, at least until you have a whole new turnover.
But I think you have to be realistic about your expectations. No matter what you do to set this up to be a fantastic part of your department, there's going to be some growing pains, and then you just have to roll with them. So rather than just say oh, nobody liked it, we're just going to quit, I think you just have to say culture change takes time. Probably takes 2 to 3 years on a probably on an optimistic scale before people just completely change the way they think about processes that happen. And so, you do the best you can to make it enjoyable. So, did we ever hear anybody grumbling about the schedule? Oh, I gotta do this. Yeah, I mean, yes, we did. So, but universally, the feedback we've been getting is either, supportive or very positive. We've got very little grumbling after the fact. People are very appreciative of the efforts that we've gone through to try to make our department and the education that the people in it receive better.
I think Simran, you wanted to say something?
Does the program. There definitely is some grumbling, but as a new faculty member, when you see that your co-faculty member who's been out 20 years is kind of engaged in the session, that kind of helps. There's still people who show up late, things like that, but it's usually not new faculty. I think like that was part of the 7 years of what these guys did. There's definitely still grumbling, but I think like once people get there and they're engaged in the activity, they're into it. And some of the things that help is the fact that Saloum's added and Amish is there and John Marshall, our chair, comes to these things and is on time and things like that.
I saw a hand somewhere over here. Oh, sure.
I wondered if you could just talk a little bit more about your modules, like how you're setting them up, how you're doing the assessment pieces of them, some of the nitty-gritty since we have a little extra time.
Sure. I'm a simulation person, so naturally we do a lot of simulation. It sort of depends on what the module is and exactly how it's structured, but specifically with the assessment piece, we don't assess in public. So oftentimes we'll talk about tips, tricks, best practices. We'll go over to the mannequins. We'll do some stuff. We'll try oftentimes to integrate what we're doing into sort of the larger clinical system. So for example, creating a safer checklist for procedure X that can also be integrated into your EMR. But then when we get to the assessment piece of it, as sort of the module is moving on, oftentimes what we'll do is we'll have we have a couple faculty members and we'll have a couple rooms. People will come in. We'll just say, okay, patient is here. Do it. We have a checklist. We mark it. Then we go over the checklist and just give targeted feedback. That's what deliberate practice is about. And I think we've done some modules with the assessment, some without. And I think what happens sometimes with the without is like I think what we typically do. Everyone kind of gets around the task trainer and kind of does their thing. But you don't really know if someone's learning it or not until you just put them there by themselves. And we're sort of very transparent about the fact that there's no negative consequences of, not performing well. It's really just all about being altruistic and try to get people the most skills that they can within a 2-hour period. Right. So the question was, is one module 2 hours? So yeah, in terms of scheduling, we'll have anywhere from probably 3 to 6 faculty members, depending on what the module is, and we'll cover about 2.5 hours or so usually. But part of the time we sort of built into the modules where everyone just sits around and chit-chats about the patient that they saw or whatever, and it just sort of builds a little bit of that. Everyone's decompressing, hanging out, and then we kind of get into it. But so, if we were really strict on time, we'd stick to 2 hours. But because we sort of allow it to be free-formed, it usually will go about 2.5. So 3 to 6 learners once a week. And then we can, those who are teaching can, make their requests to be able to be present, especially if they're not part of like our core simulation group. If we have, let's say, a content expert doing ultrasound or something else, they can also schedule time with us.
She had asked about your assessment forms, I think, also, right? And I think a lot of them have been homegrown and evolved over the years, but, Amish is actually the guy who has gone from just copying checklists out of Rosen's to really developing some, fairly robust, assessment forms with, scales and anchors and and a few things peppered in there that can actually be pulled for research later. So
Right.
if you want to
Kill as many birds with one stone as you can.
yeah.
More questions?
You mentioned that you have 60 faculty members and all of them are participating in this. So that means that you, as the educator, have to do these modules 10 times?
Yes.
How do you avoid getting bored and fatigued on that yourself?
Maybe my fellows can say. We have over the years. So the question was, if you guys didn't catch it, how do you break up the monotony of having to teach the same thing over and over again? Yeah, you know, it's. I think we have a big group. We have fellows coming in and out. Our simulation division is finally growing. So it's not just one person doing it over and over and over again. But I mean, that's the way it was sort of in the beginning. Like anytime it was airway, it's like an interest of David. So like he'd be there on most Wednesdays, and it'd be a group of maybe 2 or 3 of us, kind of doing a lot of the heavy lifting. And but now our group's a little bit bigger, so I can sneak away and not have to sort of do it all.
So not being there for every module every week, it may sound like easy for me to say, speak on the behalf of the people who generally are there time after time, but I don't think it's really any different than, say, the clerkship director who teaches the same subject matter to a new group of students every 4 weeks, or even our ultrasound division who has to gets people residents rolling in and out every single block, right? But I think that Amish had mentioned on multiple occasions is that even though they do the same module over and over again, because it's with a different group of people, you often get a slightly different flavor of what the conversation is like. And because we make this a collaborative peer-to-peer process and try to draw from the experiences of not just the people given the module, but the people receiving the module, I think that there is something to be said that it's not quite the same every single time, even though we try to standardize the delivery as much as possible.
Yeah, it's true, actually. I do feel like I actually end up getting something personally out of it because I'm hearing the tips and tricks of all my colleagues and all their accumulated experiences. So it's maybe not quite as monotonous as sort of the clerkship version of it, where you're just doing like approach to abdominal pain. This is really like higher level learning and sharing of experiences.
I guess I just want to comment on that there are also many different ways to do this. This is a great example, but you can scale it to like how many people you have available in your shop to do the teaching. There are lots of different, faculty development, SIM-based programs going on. And I just wanted to put a plug in for there's, if any of you are involved in simulation specifically through IMSH, there's a group that's actively kind of surveying people across the country on what people are doing for faculty development processes like this. So if you're interested, I can hook you up with Beat on that listserv.
Awesome, thank you for that.
Look, someone in the audience giving out, sharing with the process too. So this is exactly what I was trying to say about how, we get something from the people in the audience as much as we're able to give it, I think.
Any other burning questions? Okay. Thanks, everyone.
Yeah, thanks for being a very engaged audience. We appreciate your time.